So as you know, this is a kind of emergency lecture because some of you are going to an exam in a few days. And it's really difficult for me because I'm going to talk about complex strabismus cases. So we kind of uh, beginning our talk in strabismus by difficult cases. But because these cases are commonly in the exam, so presented in the exam, so I like to start talking about Duane syndrome and Brown syndrome. All right, and this is the first part, and this is a time frame, but because this is an interactive lecture, so probably we'll finish Duane retraction syndrome in this meeting. So we have an opening slides, and then we will talk about Duane retraction syndrome. All right. And as you know, letter S is one of my favorite letters. So I asked you to study Duane syndrome, Brown syndrome, force reduction test, Hess chart, and to be optimistic. And if you notice that today is Saturday, September 17th, so we have a lot of S's here, and I hope the success for all of you. And don't forget to study smartly, especially in these days, because I guess you are stressed out because of the upcoming exam. So try to focus on high yield questions and study by pictures and practice speaking and with your colleagues. All right. And this is not comprehensive. I'm not going to talk about the Duane syndrome, everything about Duane syndrome, for example, but I wanted to stress on some concept. So it is a kind of conceptual lecture. And some of you, I think more than one, said that strabismus is scary. And of course, there are a lot of reasons behind this word. And because there is no shortcut for strabismus. You have to go through the basics and the foundation in order to understand the abnormalities. So you have to go through the anatomy and physiology at first. And as you know, lectures, some of the lectures are lengthy and boring. References are not clear and confusing. You will find the discrepancy between references. And when it comes to cases, there is a lot of variation in the signs, and we have a lot of exceptions and unexplained findings. And whenever you try to practice strabismus, you will face children, uncooperative children, and it is tiresome examination and long follow-up visits. And finally, somehow humble financial and reputational gain. And some of my friends send me this photo. As you can see, this is the car that belongs to a squint surgeon. And let's see, but the good news is usually in the final FRCS of the exam, they will give you a classic typical cases, like type 1 Duane syndrome with gross manifestations. So you never miss if you already know what does type 1 Duane look like. Okay, all right? So don't be scared. And we all love Kanisky. And yesterday I checked the last edition. He added some new things like new terms and genetics, but still there is some confusing sentences in strabismus chapter. And I think some of you may need help during studying strabismus from Kanisky, because some points are confusing. So again, this lecture is exam oriented and it is highly interactive. So most of the time I will ask you and I expect you to answer. And don't be shy to participate. And don't be afraid of making mistakes. We all make mistakes all the time. And try to be interactive and don't be inert. All right? Is it a deal? You can interact with me like yes, ma'am. Okay. And finally, don't be scared. I hope by the end of these lectures, you will be less scared about strabismus. And I'm trying my best, actually. So you will find a lot of diagrams, cases, videos, some perhaps, and photos in order to make the picture more clear for you. And I advise you take notes and ask questions in the chat box whenever possible. And as you know, I like emojis. Okay, the internet is breaking. So I overuse the use of emojis because I think some of the emojis, as you notice, send positive emotions. And I made the negative emotions smaller. And the biggest one is this one because it's all depend on you. So your success is the responsibility of you. You have to do all your best. All right. Sorry. So let's begin with the opening slides. It's a kind of warm-up, brain warm-up. So let's start by this slide. So in Viva, they may give you a photo, a printed photo. All right. So does this slide remind you by something? Let's see. This is my first question for you. So they are empty rectangles. So it should be photos inside each rectangle. So does this diagram remind you by something? You can unmute yourself and answer.
The central 9 boxes about the 9 positions of gazes. Is that what you want us to answer, ma'am? Can I try?
Yes.
Like that?
This is this. So one answer at one time. So who's on?
So, ma'am, this is Hasika, ma'am.
So Hasika. So
Yes,
this part of the slide reminds you by the 9 gazes, right?
Yes, ma'am.
So we can say the positions, different positions. So this is called the cardinal or diagnostic positions. Do we call it cardinal positions or diagnostic positions? All these 9 tabs. Okay, let's make it more clear. So this is the primary position. This is the primary position?
Yes, ma'am.
All right. So make your mic unmuted. And this is what we call this gaze. Hasika.
Levo version, ma'am.
What we call this gaze. The name of this gaze.
Left gaze.
Left gaze or Levo version. Okay. And this is looking at the right side. So this is dextro version, right?
Right gaze.
And
yes,
here up and to the left, or we can say it Levo elevation.
Levo elevation, yes.
And here dextro elevation.
Dextro elevation.
Here Levo depression.
Levo depression.
And dextro depression.
Dextro
elevation. Depression.
Elevation. Depression.
Okay.
Yes, ma'am.
So these are called the 9 diagnostic positions of gaze. So if we confronted with a picture like this, we call it a composite or a composite picture. It is somehow confusing because you have to focus on each photos, but start by the primary position, then look at the horizontal gazes first, because most of the time the signs are in this row, in the middle row. And sometimes they may give you additional photos like head tilt. This is just a guessing. I'm not sure, but in our exams, in our national exams, they may give a candidate a printed photo of all these positions. So right head tilt and left head tilt, they may have signs, and they may present to you an abnormal head posture, like in this photo, like the external view, and they may give you a photo for alignment in a distance versus near, like in cases of esotropia with high SAA ratio. And for accommodative esotropia, they may give you two pictures, one with spectacle and the other one without spectacles. And in intermittent exotropia, they may give you two photos. And the examiner said, this is at one time and this is at another time, so it may be intermittent exotropia. And they may give you pre and post-operative pictures. And you will find these variations in the textbook as well. And try to look carefully at each photo and while studying, and look carefully at the legend below each photo. Here, remember, when you are testing down gazes, you have to elevate the upper eyelids in both sides. All right. So suppose in the clinical exam you are going to test the version, you have to like warn the patient or ask for permission to touch, because you are going to touch him or her. So this is, you have to say it while you are giving the instruction, for example. So during version testing, you are holding a target in different gazes. And so you ask the patient to look at the target. So you have to check the vision in each eye at first, and then ask the patient to look at the target and warn him that you are going to touch his eyelids, to elevate eyelids while testing. Okay? Sometimes the arrangement is different. Like in Kandinsky, they present here a composite picture of 3 photos. The upper one represents the primary position, and the middle one is levo version, and the bottom one is dextro version. So supposedly the examiner will tell you the position in each photo, but try to practice to know the gaze without reading the comments below the photos. So while studying, try to expect the finding and the gazes before reading the comment below each photo. It will help you a lot, because in the exam there is no comment below the photos. It is supposed you will answer the sign, tell the examiner about the signs. So the first step, to be sure about what gaze the photo is showing. So in the bottom, in the middle photo here, if this the primary position, you may say this is unright esotropia. So the abnormality may be in this eye, but actually this is a levo version. So the abnormality in this eye, because this eye, the left eye is not moving out. It is not abducting, not abducting. So it's really important before you mention the sign to be sure what gaze the photo is showing. Don't expect better quality photos. For example, in the first photo here, in the top photo here, Kandinsky said it is a straight eyes. He means the orthotropia, but actually the patient is not looking directly or coaxially to the flashlight. So as you can see here, the Hirschberg test, or the corneal reflection, is decentered here temporally and decentered here nasally. But because the decentration is equally, so it is most probably an orthotropic patient. And so sometimes the photos is not looking exactly at the flashlight. So when you answer, don't try to add seemingly, the word seemingly. So it seems that the top photo is orthotropic. So what is the importance of adding seemingly, or it seems to be orthotropic? First, because the patient is not looking at the flashlight. Second, you depends on Hirschberg test, and Hirschberg test is a rough test. The only sure test to document the presence or absence of strabismus is cover test, not Hirschberg test. Because Hirschberg test could be central in both eyes, and the patient has a squint. And so we have false negative results. And sometimes Hirschberg test is decentered in one eye, and this eye actually, there is no squint. So this is false positive, like in abnormalities of angle kappa, like pseudo squint. All right. So once again, when you answer or you comment on signs on a photo, you can add the word, it seems to be orthotropic. But here in the middle photo, don't say it seems there is a limitation of abduction, because this is a limitation of abduction, because this is in abducting, this is abducting eye here is normal, but here the abduction is almost zero. So the eye doesn't move beyond the midline. All right. So my next question, what does the slide remind you?
A motility test.
Testing the ductions, ma'am, in each eye.
Okay.
Field of action of
Actions of muscles. So like a grading of muscle action, like yes, correct. So here, so suppose this is the target. You see this target. So the patient is looking to the left. This is levoversion. So here you are testing what? You are testing the action of the lateral rectus in the left eye and the medial rectus in the right eye. And we call it these two muscles yoke muscles. So when you are testing the lateral rectus in one eye, you are putting the target on the same side. We call it ipsilateral target. So the ipsilateral target here is testing the lateral rectus, but this target is considered as contralateral to the medial rectus. So that's why we tell the undergraduate students, when you wanted to test the medial rectus in one eye, you have to put the target on the contralateral side, because you are testing here the medial rectus of the right eye. So you put the target on the left side. All right. Now, if we put the target here, so you are testing the lateral rectus in the right eye, and in the same time you are testing the medial rectus in the left eye. And if you put the target here, can any of you tell me, when I put the target here, do you see? I'm testing which muscle in the left eye and which muscle in the right eye. So the more you interact, the greater you will benefit from this lecture. The muscle which is responsible for elevation in abduction is the superior rectus, and the muscle responsible for elevation in adduction is the inferior oblique. If we put the target here, up and to the left, okay, and in this, and the left eye elevates nicely, so the superior rectus is acting nicely, but the right eye doesn't elevate. Again, in this position, levo elevation, the left eye elevates nicely, like normal, but the right eye doesn't elevate. So we say either we have inferior oblique under action, or the antagonist here, the superior oblique muscle, is contracted, like restrictive. So whenever there is a defective in the action, it could be due to paralysis of the responsible muscle or contraction of the antagonist muscle. All right. put the target down and to the left, we are testing the inferior rectus here and the superior oblique here. So the inferior rectus depresses the eye in abduction, and the superior oblique depresses the eye in adduction. So target on the left side, you are testing the lateral rectus in the left eye, and in the same time you are testing the medial rectus in the right eye. So what's the significance of this? What is the clinical significance of this? Suppose the patient has limited adduction due to some problem in the medial rectus. Suppose the medial rectus is not working, okay? Or the action of the medial rectus is like -3 or -4. So once again, if we have medial rectus under action in the right eye, the problem is looking to the left. So the left gaze is problematic to this patient. So the patient will adopt a face turn to which side?
Ma'am, opposite
And this is
side.
my question. So Dr. Hasika, so the face turn will be to the left side. So the patient will adopt left face turn. So in the strabismus language, we call it contralateral face turn. So if we have medial rectus under action in one eye, there will be contralateral face turn. So here is the medial rectus in the right side, so the patient will adopt left face turn. All right, so medial rectus under action will cause contralateral face turn because medial rectus is acting to the contralateral side. Another example, if the patient has a problem in the lateral rectus, like 6 nerve palsy, the patient will adopt left face turn, again, the same, because the lateral rectus is acting to the left, the lateral rectus is acting to the left. I think I hope you got this clinical significance. So medial rectus under action will cause contralateral face turn. Lateral rectus under action will cause ipsilateral face turn on the same side. Okay. Back to our slide. So if you put the target on the right side, so you are testing the lateral rectus here and at the same time the medial rectus here. If we put the target left and up or up and to the left, so we are testing levo elevation. The muscle which elevates the eye in out position is the superior rectus. At the same time, the inferior oblique elevates the eye in adducted position. In levo depression, if we put the target here, the inferior rectus is acting here, and at the same time, the superior oblique is acting here. If we put the target up and to the right, the superior rectus is acting here. Finally, if we put the target down and to the right, the inferior rectus is acting here, and superior oblique, the yoked muscles in this eye. How about this sentence, when 0 is good? Because in this H letter, when you document the finding, for example, if the left eye is abducting nicely, like full movement, we call it 0. So here 0 means normal action. But if the muscle is underacting, there is grading for underaction, like -1, -2, and -3, and -4. -4 is like no action at all. And sometimes the muscle is overacting, like in inferior oblique overaction. So we can grade the overacting muscle by +1, +2, +3, +4. All right. So 0 here means normal action. And this is from Kanisky. Again, as you see here. So as you see here, in this color code, we have something called cardinal position. So cardinal position, we have 6 cardinal positions. What's the meaning of cardinal position? So cardinal position, if you see cardinal positions, means levoversion, dextroversion, levo elevation, levo depression, dextro elevation, dextro depression. So all three here and three here, this is called cardinal position, because in this position only one muscle is acting in each eye. So when we test like the levoversion, we are testing the lateral rectus in the left eye and the medial rectus in the right eye. So each one muscle is acting in each eye. So this is called cardinal position. But if we are asking the patient to look up or to look down, so during the up gaze, it's mainly by superior rectus, but also the inferior oblique is acting. So we have two muscles are acting in up gaze in each eye. And likewise in depression, in each eye two muscles are acting, the inferior rectus and the superior oblique. So up gaze and down gaze are not cardinal positions, but still they are important. Important when we have to document the presence of pattern strabismus. So do you know what is the meaning of pattern strabismus? Pattern strabismus. Make it clear, alphabet pattern strabismus. So up gaze and down gaze are not cardinal positions, but if the case has a pattern like V pattern or A pattern, we know this from the up gaze and down gaze and primary position. And it is written in Kaneski, so you can recheck the V pattern and A pattern in Kaneski.